My pleasure to chair this session with Dr. Murray and to introduce a novelty in the program of our meeting, that is the first edition of the Johannes Clemensen Lecture that is offered by our colleague Hans Storm, who is the successor of Dr. Clemensen. I was remembering with Hans that Professor Enrico Aglesio, the establisher of my registry, was born in the same age than Johannes Clemensen, 1908, and when he started establishing the Torino Cancer Registry, he traveled to Copenhagen to meet Dr. Clemensen and to learn from Dr. Clemensen. And both had very long lives. Dr. Clemensen died at 102 years, Professor Aglesio 95 years, so maybe the job of establishing cancer registry assure longevity. Hans, please.
Thank you, and I can second everything that David Foreman said this morning, thanking the organizers for this opportunity and this challenge. And indeed, Harry, this has really been a challenge. I had to read a lot of Clemensen's books and study his life. And doing so, I'm getting embarrassed. Oh, it's yellow now. Yeah, great. It doesn't help if we change it, but you can see it in yellow. And due to the number of slides we have to push on, irrespective of the color that you see, it's beautiful on this screen. Okay, this is the young Johannes Clemensen from 1942 when he founded the Danish Cancer Registry. I was so lucky that I got an employment with him in 1977 as medical coder, doing my internship in surgery at the Finsen Institute, the cancer hospital in Copenhagen. And I experienced Dr. Clemensen in the evenings when I was on watch in the ward. And I did some coding in my spare time. And suddenly I heard something rumbling in his back office. And I discovered Johannes Clemensen sitting with some frying pans made out of this not rusting iron, whatever it's called in English, on a Bunsen burner, heating up hospital food that had been delivered to him at noon. And he is actually the living example that hospital food is really healthy. He lived until he was 102, and only since he became 96, his family, nephew, and other family members took care of him. But this is a picture where he was finally acknowledged for his work. I mean, we have to wait until we are 96 to get the acknowledgement of what we've been doing. That was from his employer, the Danish Cancer Society. It's a bloody long wait to get acknowledged. He died, as you can see, almost looking better than at 96 at the age of 102. Just before he died, at his 100th anniversary, he discussed his life with his relatives and said, "I've had a very interesting life. I really experienced a lot. I've been traveling a lot. I never married. Maybe that's why." Now, diving into history is interesting. So in 1942, I found this newspaper article in one of the national newspapers where there was this headline, "The Cancer Card Index Show the Way to Cure." That was 6 months after he initiated the Danish Cancer Registry. And he already had a number of pertinent questions. Is cancer increasing due to aging of the population? And he calculated that every 6-hour citizen in Copenhagen died from cancer and predicted that in 1980, this would be 1 every hour unless we find a cure. He reported also that notifications for cancer registration from hospitals is the backbone of the registry, and he also made an inference to what we saw earlier this morning, that death certificates is a problem. They are not accurate, and actually he blamed that on the GPs because they have difficulties in assessing the right diagnosis. He reported at that time that breast cancer is very frequent. Stomach cancer predominates in rural areas. Actually, he sent out an employee to determine what was rural and what was urban in Denmark. He didn't believe in the national statistics, and he was right in that. And he also discovered at that time that the cancer pattern differed between the workers of the hand and the workers of the mind, as is bluntly stated in this newspaper. He believed that we got older due to better personal hygiene and social matters. He had himself contracted tuberculosis a couple of years earlier. And then he asked a few questions which we still ask ourselves. Why do some people get more than one cancer? And is there a link between cancer of the ovary and the breast? Could it be due to hormonal factors? This was 1942, ladies and gentlemen, based on half a year of cancer registration. And then he proposed for the future, added value with more generations on the file, genetic epidemiology, ladies and gentlemen, that was already foreseen in 1942, and the study of twins to get a little faster to the results. When you are a pioneer, just like Everest, you often, or Burkitt, you often get a disease or something prestigious named by your name. And Clemmensen, he discovered this, the hook in breast cancer that indicated that there might be two different diseases. And Clemmensen's hook is actually rather famous. It, however, disappeared by time. And today it's completely gone, and we've got a new hook that's called the mammography hook due to screening with mammography in the country. The reason why he found that hook was that he was not accepting the stubbornness of British statisticians using 10-year age groups for mapping out age-specific incidence or mortality. He rather preferred 5-year age groups, and that was how he found the hook. Nowadays, we would even dream of what we do 1 year or whatever we can do. So this is books placed on my shelf. I was extremely lucky that Clemmensen didn't dislike me. He accepted me. So he gave me all his publications, which are in the blue books. That's the scientific publications, nicely bound, and the important cancer registry publications, statistical studies in cancer, which are the red ones. This is the scientific public production of Johannes Clemmensen since 1934 to 1968. And if you open the book, you will see a lot of articles bound nicely into this publication. And mind you, some of them are in French. I mean, we were always told, or has been told before when we had a meeting in Africa, in Abidjan, that you could not produce scientific literature in French, you had to do it in English. But this is a living proof that that's not true. The best volume of Clemmensen, and I can recommend all of you try to get hold of it or borrow it from somebody, is the Foundation and History, the Review of Cancer Epidemiology, which he did in 1965. On this, he is also summarizing cancer registration and the history of epidemiology. And what is important here is his statement that also was at the meeting in 1946, and David already told about that meeting, so I'm not going to repeat that, is that the collection of data that we do serves the basis for individual follow-up of patients, to produce reliable morbidity statistics with a view to accurate estimate of therapeutic results, accurate evaluation and variation in incidence of malignant neoplasms, secular, geographical, and occupational, etc. And here he used the term geographical pathology. Clemmensen was a pathologist. And of course, later this was called endemiology, and that was later changed into epidemiology, which is much easier to say than the other words. But more importantly, cancer registration is to establish nothing but a basis for research. I think we should remember that. Cancer registry tools has evolved over the years. On the left-hand side, you see the famous worker with the card file of the cancer registry, and 50 years later, another employee working with the microfiche file, because the paper file grew to enormous size. At that time, there was about 1 million records in the cancer registry. 1943, Clemmensen did the quality control. Another well-known character did it in 1993. Same procedures everywhere. Now, on the left-hand side, you see the computer of the old times. That is a card with holes at the rim of the card and a scissor which is placed here, a special scissor by which you could open the holes. Now, research in those days were having a whole pile of these cards put together, and then you put the knitting pin in, shook this pile of papers, and out on the desk fell the ones that you wanted to study. And then you did the counting, 1, 2, 3, and put it in. Took ages to do, but it was possible, and it's amazing what they've done with this type of computing in the old days. And then, of course, you had the calculator there. If anybody knows, this is a calculator stick, something that we used in the 60s, 70s in school as well. On the right-hand side is modern life. We employ somebody to key in the data into the computer, and we ask for printouts of what they shook their way to get in the old days. And here you have a very well-known prestigious researcher, Henrik Møller from the Thames Cancer Registry, when he was a young researcher studying testis cancer. I thought he would be in the audience, but anyway, you can tell that you saw his ponytail, which has now been cut off. Now, modern cancer registration, ladies and gentlemen, is in Denmark now one person. We have now 3 databases, main databases: the patient registry, the registry for pathology, and the primary healthcare registry, and of course the old cancer registry, which all feed data into a computerized system. Out comes the data. Here comes 20% of the cases that need scrutiny by the coder, the only remaining staff member of the Danish Cancer Registry today. Puts them in again, and luckily it ends up here, and we can extract the data. And this, of course, is due to the excellent linkage possibilities we have and still have in the Nordic countries based on our unique ID. And Nordic collaboration is also something initiated by Clemmensen. He was the first one, and he helped other registries to emerge. He always said that, I'm really sorry I helped the Swedes doing it because they made a different system he didn't like. But anyway, they had a symposium in 1955 where they pointed to the fact we need a European cancer registry. We're still working on that, ladies and gentlemen. Let us now open the book of Clemmensen, which shows us the way from cancer epidemiology to what I call translational epidemiology. And I'll get you into that in a short term. Remember the word, translational epidemiology. I think that's worth a lot of money when you apply for research funds. Anyway, Clemmensen, he started very early with Agricola from 1556 in his book. And actually, what is interesting here is what was in red, that Agricola found that the dust eats away the lungs and implants consumption in the body. I mean, the wording is different, but that was pneumoconiosis, tuberculosis, or lung cancer that they discovered. And it was really a serious disease because women are found who have married 7 husbands, all of whom this terrible consumption has carried off to a premature death. So you could actually had to marry 7 times as a lady to survive. Now, Ramazzini was the father of occupational medicine, and Clemmensen here cites him for what is important: hygiene, welfare, ventilation, and protective clothing, and I think that's still valid. He moves on to John Hill, who investigated cancer and declared tobacco snuff to be the cause of cancer of the nose. And we know, even in Sweden, we have also now discovered cancers in the oral cavity. And moves on to Percival Pott, who noted the high incidence of scrotal cancers in chimney sweeps, linking that to cancer to soot. And this was the guy that got the scrotal cancer, the young one, that was sent down the chimney. And we couldn't figure out why did they not get scrotal cancer in Denmark. It turns out that the clothing in the UK, or what it was Britain, then England those days, and Denmark was different. And the Danish little chimney sweep was actually protected by his clothes. In translational epidemiology, maybe John Snow is the best model looking into the water supply in south of London, where he did the mapping of cholera cases around the Broad Street. And here you have the Broad Street pump, and you can see how the cases of cholera cluster around that pump. And other pumps are out here, and there was no cholera cases. Now, the cause of it was these creatures that was pulled out of the sewer that had eaten their way into the pipe system. But the cure, that was truly translational. He removed the handle of the pump in the Broad Street, and it's still there as an example to us how simple measures can change life and death quite fast. But that was a kind of mapping that also was adopted by cancer registries. And here you see Clemenson with his chief statistician, who spent a couple of months putting in small dots on the map on the right-hand side, which is cervical cancer in Greater Copenhagen. And from this map, you can see the density in the center of Copenhagen, which is here. It's much more dense than up here in the northern part where the rich people live. So already in those days, mapping actually gave us some results. And later on, we moved on in the Nordic countries to make maps, and the first ones was the Ole Jensen maps, which is here on this side, where you can see the borders between Norway and Sweden and Finland and Denmark here. Testis cancer in the Nordic countries respect borders, administrative borders. Well, we've had researchers spending a couple of decades trying to figure out if this was correct. We haven't been able to find any mistakes in the data, but we have a quote from Clemenson saying that if an epidemiologist is unable to figure out that large differences, is unable to figure that out, he should find another job. And he donated his money to a research fund that actually is dedicated to study this. The Eero-Pukala maps we've seen with the smoothing, this is not the moving ones, but you can see the movings on this link. But what you see there is also the measles. There's some, which is the cities, and some Eros maps is on some of the posters around here. That's perhaps a better way of visualizing cancer. Also cancer trends. Now, I've skipped the meeting in 1946, but I'll move to the meeting of the UITC in Louvain, 1952, on the epidemiology of lung cancer. And here you see, first of all, Kennaway, which was the one Clemenson really looked up to, and Clemenson standing very close to him, and his long-life enemy, Mr. and Mrs. Doll, standing in the middle. And why were they enemies? That was actually the reason of this Doll study that was published, showing that lung cancer was predominant among smokers compared to non-smokers, both among men and women. I hate p-values, so let's put Doll in there. Clemenson actually saw this in 1948, but he had no beliefs in his data. He said it's a registration artifact due to autopsies. And he never forgave Sir Richard Doll that he took the pride of establishing the link. Later, he established himself the link with tobacco smoking and bladder cancer, and was pleased about that. So already in 1965, he mentions that we cannot do any kind of occupational epidemiology without adjustment for the effect of tobacco smoking. And I believe he's right. It's difficult to get anything published in occupational epidemiology if you can't adjust for smoking or other habits we know causes cancer. In this association in Canada, Bruce Armstrong showed the role of registries in cancer control. he actually outlined a situation which was not very satisfying for registries to learn, that we were in the back room, meaning that we were invisible and everybody just believed the data would be there, whatever we did. We only produced something on cancer pattern and care and outcome, and provided a research base for others, and we didn't exploit it ourselves, which he said was a mistake. And he made a survey in those days, and we haven't repeated it for this meeting, but he said that most registries would fit this mold. 16% only collect data, which means that they don't even present data in 1992, they just collect them. And he said some do research and some monitor for cancer control, which means that nobody was doing the whole package. He proposed at that time that we should have an expanded role in cancer control, and we should move to the front room if we wanted to survive. And that is something we probably struggle with, all of us, sustainability for the cancer registries. Maybe the Danish solution of getting everything automated into already computerized data is a way forward in many places, but that requires a lot of quality control when you have linked the data, and will put a burden on the research to secure quality is okay. In those days, the Nordic countries had made an agreement amongst them to join forces to produce a lot of interesting publications over a long period called the KIN project. Floridis Langmark was part of this project, and one of the, at least she was the budget holder, and had to steer all the mad Norwegian researchers involved in this. But the first attempt was the most boring publication I've ever been doing in my life. That was produce a joint incidence publication with similar definitions for all cancer sites in the Nordic countries. Baseline work, tables, proofreading, tables, proofreading. I mean, that is really, really, really tedious. But more interesting was this one, the first joint prediction publication, which has given rise to the prediction models we use today in our work. And it showed both the impact of population changes and changes in research. Today we use the Nordcan and produce what we were 3 years to do in about 1.5 minutes. We have the results out of the Nordcan predictions using the same tools and with the same kind of data, where you have the differentiation between the change due to change in population aging and the change in what we call risk. And you can here see for lung cancer for men that in fact the risk is decreasing. We have fewer cases than expected. However, we have about the same patients in the beds, which is interesting for administrators and cancer control, that will have the same number of patients. So this is useful for cancer control. And on the same time, you get these graphs that shows the trends, both the crude rate here going up and the age standardized, showing that we actually have managed to do something good. And today we have a lot of possibilities. If you use the website of IARC, you have GloboCan, CI5, Axis, you name it, ECO. Open sources, easy and fast web access. You can get the descriptive epidemiology in few seconds. It's comparable data quality. At least they've spent a lot of time trying to make it comparable. You can export relevant graphics. You have excellent tabular possibilities. Some of the data is really timely. If not timely, they predict what should be there, and prediction is a possibility. And now the ECO website is the latest in this family. Excellent website. I hope you all tested it before you came. It was launched a week ago, it's just about. Fantastic graphical possibilities. Thank you to Harry and his team that was behind this, and to David's team as well. Now in Nordcan we also did prediction based on mortality. We don't believe in mortality, so we used the incidence and predicted based on survival estimates. And this gave rise to a study on survival. And we estimated also the potentially avoided cancer if we had done an intervention on the risk factors the year we had sufficient evidence to advise this to the population. So the survival figures is something we do repeatedly every 5 years. We have here on this very busy graph incidence on the left-hand side, the mortality in the middle, and the survival, 5-year survival, real survival on the right-hand side. What you can see is Denmark has the highest incidence, that's the black graph. We have the highest mortality and the poorest survival. This woke up the politicians and gave rise to cancer control plans in the country. And this one, even more so, the excess mortality, where we can see the excess mortality is high in the early period after diagnosis, and it's virtually gone after 1 year. So we can, out of this, do something that really interests politicians. We told them, well, you see, in Sweden, just 17 kilometers from the Ministry of Denmark, they do so much better that we have in Denmark around 1,500 additional unnecessary deaths from cancer compared to the Swedes. We'll lose in football in the long run. We already did. And that is still the case in 2004 and 2008. But we're catching up a little with the Swedes. We also had this from the avoidable cancers, the potential that, that we could prevent. Max Parkin made an excellent publication that has added on some more percentage points from the UK situation. So it's actually quite robust. And I must admit, quite robust from what Peter and Doll did back in the 1980s. And the same, we come up with almost the same estimates. For cancer control, there is a need to a marriage with clinical databases. And Professor Lars Holmberg from Sweden had an editorial in the Acta Oncologica recently where he posed the question, can national cancer registration support clinical databases and clinical research? He also gave the answer, yes, and if not substantially now, we'll make sure it can in the future. It will be really important for us to be able to do the staging, and I think Helen's presentation this morning was excellent. There will be tools that can stage our cases in the cancer registry in a very comprehensive way using new technology and thereby make something that is comparable across a country or across countries if we use the same methods. The other thing that we heard about was molecular biology, and that's also an important one, especially since we already in 1996 learned that we had solved the cancer riddle. Unfortunately, the problem is it is so damn complicated. But today we hear clinicians saying that after mapping of the human genome with 3 million base pairs, we are now able to sequence the genome and identify mutations in a short time. Actually, we're talking about 1.5 hours in the hospital setting where you can sequence the genome today. And they continue, every tumor and person are unique. With new techniques, it's possible to develop a strategy for both treatment and follow-up of each single patient. This is really something new. The knowledge we acquire is necessary to prevent the cancer diseases. So we will have to play a role in this new setting. But we also have to acknowledge tumor biology. We have a lot of cells, 10 to the 13s, with over 10,000 DNA damages per day. And mind you, we only need about 5 to 6 driver mutations to get a cancer cell. And if we have more than 30 cell divisions or 1 billion cells, we have 1 cubic centimeter of tissue, and that's the diagnostic level for a cancer. And if we look into that, and remember this really simple slide from tumor biology, you can see when we get up into the diagnostic level, which is here, the embryonic testis cancer is about 2 years old. The colon cancer, on the other hand, is almost 14 years old, if this tumor biology is correct. Well, moving on to an entire country as a cohort, which is the situation in the Nordic countries with our ID numbers, we have the possibility to link the cancer register to a lot of databases. This is the medical database linkage possibilities. We can look into prescriptions and follow patients, cause of death, hospital in register of abortions, medical birth registers, etc. And we do it based on solid hypothesis, because unless you have a hypothesis, you're not allowed to do the linkage. And we did a massive linkage to study social inequality and cancer survival, taking the whole population, 3 million people here, aged 30 years at the entry, studied 148,000 cancers or had 25 million person years. And in this linkage to the national statistics, we get the education and disposable income. That's the two most important ones in social inequality. Hospitalization, so we could correct for other diseases with the Charlton Index, so comorbidity was taken into account, and looked into the different cancers. And what did we see? Surprise, surprise, those with high education do fare much better than those with low education or no education. And that applies to the whole population, but also applies to the observed ones even more, and it doesn't matter if you're a man or woman. So here is a whole new avenue that we need to study more in detail. And maybe molecular biology and biobanks can help us, because that is the future. This is a new national Danish biobank. This is the institute that now hosts the cancer registry and all medical data in Denmark. So essentially we can go onto the web and look into what kind of data they have, and then we can start requesting if we can see that this is possible. So what has we achieved in 80 years? Coverage, speed, and quality of registration has been improved. Computerization and some integration of the computerization into the daily life. Web access to basic statistics. We know risk factors for 44% of all cancers. We know that there is a role in cancer control. We are acknowledged as cancer registries and asked for to give the incidence, mortality, survival, prevalence, and study of screening. We have the possibility to link to clinical databases and hence the outcome in a much better way. We can link to biobanks, auxiliary databases for use in public health as well. But there is a need for more registries in the front room still. So it shouldn't just be the few registries or prestigious institutions that are doing the research. We should actually be there, all of us. I'll finish off with a quote that Sir Richard Doll came with, that effect of life is that with so many known carcinogens in the environment, it is a lucky man who manages to get out of this world alive. And because that's a little joyful thing, I will end up with something which is even more serious. That's the confidentiality issue we'll talk about later this week, because data protection may impede the possibility to function and do research in the future. And this little cartoon shows and pinpoints that quite clearly. Thank you.
Thank you. Yeah.
Okay.
Okay, thank you.
Okay, so we'll go now to the first of our presenters, Dr. Sultan Izer, Professor Sultan Izer actually, who is a professor of public health from Turkey, the founder and director of the Cancer Registry in Turkey since 1995, and she has also heads up the Cancer Control Department in the provincial province of Izmir. So, Dr. Izmir.
Is this the tool for...
Thank you. Actually, I feel very unlucky since I'm at scene after Hans Storm's very colorful talk. But I hope I will not bore you. Our study is recent trends in colorectal cancer incidence and mortality in Southeastern Europe for 999 and 2008 period. We did the study with the colleagues from the Southeastern European countries. I can find the arrows. Sorry, okay, sorry. Thank you. This study is an outcome of the meeting which was held in Iași, the beautiful city of Romania, in the scope of the work package age within the framework of Eurocourse project of ENCR. As it is well known, colorectal cancer is fourth most common cancer in male and third most common cancer in female worldwide. And it has traditionally been one of the most commonest malignant disorders in the developed countries, in the developed populations. However, recent reports, recent studies has reported decreasing trends in mortality and incidence rates of colorectal cancers in developing countries, in developed countries, US, Canada, New Zealand, including Western European countries. Despite this fact, in the developing regions of the world, we see a rapid increase in colorectal cancer incidence rates and mortality rates as well, especially in the economical transitioning countries. So we would like to see that these trends, recent trends for colorectal cancer incidence and mortality in Southeastern European countries. And we request data from 1999 and 2008. We received data from 17 registries in 11 countries. And after the evaluation, we could analyze the data from 8 countries for this reason, from Slovenia, Croatia, Serbia, Romania, Bulgaria, Turkey, Cyprus, and Malta. From Turkey, it's from Izmir and Antalya regions, from at the west and south of Turkey. And from Romania, it's Cluj county, and from Serbia, it's from the central region. The others are nationwide. So we calculated age standardized incidence and mortality rates using world standard population and by the direct standardization method. Also, we applied joint point regression analysis to use to estimate incidence and mortality trends. Time trends were analyzed only for the registries and time periods with consistent data quality. So for 2008, we present the age standardized mortality and incidence rates. We see that these incidence rates especially varies from 50 per 100,000 to 8 is 20 100 per 100,000, and Slovenia and Croatia has the highest incidence rates, while Izmir and Antalya from Turkey have the lowest incidence rates, and also Cyprus has lower rates in male, of course. When we look at the mortality rates, as in my presentation, my colleagues' presentation in the morning, we don't have mortality data actually. You see, Antalya has mortality data, but this is a registry-based estimation, not a real mortality data. So the low ratio of mortality and incidence of in Cyprus is remarkable here. Then, if you look at the data among female, we see the highest rates, highest incidence rates in Slovenia again, but it's surprising because in the second row, the Cyprus is available with 24 per 100,000. It's close to the rate in male in Cyprus also. So Croatia is at the third row, and at the last rows, Izmir and Antalya also have the lowest rates. Still, we can see in females again the low mortality incidence ratios. So, if you look at the trends, we found increasing trends in incidence rates in, I can say, all of the registries which we can apply. Most of them has significant average annual % change, and for male, and also for mortality, still we found significant increasing rates for mortality, except Slovenia. In Slovenia and in Malta, it looks stable, and because of the lack of long-term mortality data in the other countries, we couldn't evaluate the trends there. So for females, still it's increasing in Slovenia, in Bulgaria, and in Cyprus with significant average annual % change. But it looks stable in Croatia and in Antalya. In Malta, it shows a decrease. It's a little bit strange because in the male, we see a remarkable increase in the incidence of colorectal in Malta, but in male, it shows a significant decrease. So, for the mortality rates in females, in Slovenia and Croatia and in Malta, it looks stable, and it's increasing in Bulgaria and Romania. So, despite the decreasing pattern of colorectal cancer incidence and mortality rates in the rest of Europe, especially in Western Europe, they still show increasing trends in most of southeastern European countries, mainly in those where primary and secondary preventive measures of colorectal cancers are not available. Okay, thank you.
Thank you, Sultan, for that in-depth view of a common cancer from an area we don't know an awful lot, well, I don't know an awful lot about, so it's good to see some of that. I'm now opening the paper for questions, if anyone has any comments or questions they'd like to make. Can I ask you, Sultan, what was the most surprising, what was the most surprising finding that in your work that you found there, and how do you explain it to yourself? How do you explain it? What did you find most surprising in those statistics?
Those statistics?
Yeah.
Actually, the increasing trends of colorectal cancers in this region is expected. It's not surprising, of course, because they are kind of developing countries, and now, for instance, in Turkey, the lifestyle has westernized very rapidly in 10, 15 years. So now it reflects to the rates of colorectal cancer, the diet and obesity, and inactivity, of course. Maybe some inconsistencies is interesting here. As I told, in Malta, for instance, it's increasing in men but decreasing in women. Yes, the colorectal cancer incidence rates increasing in male more dominantly than in female, but in this case there's a reverse movement, so it's interesting. And also it varies. The rates vary in a very wide range. It's interesting also.
Okay, thank you very much. Okay, so I'll hand over to Roberto for the next person.
Thank you. The second presentation is from Gianni Lortetiolin, International Trends in the Incidence of Cutaneous Malignant Melanoma, 1953-2008. Giovanni has a background in biology with a specialization in biostatistics and has worked for more than 7 years in epidemiology, first in the private sector and then as project manager, and in the last 3 years as statistician at the International Agency for Research on Cancer in Lyon. Please, Gianni.
Oops. Thank you. I'm pleased to present this study on incidence in melanoma worldwide with my supervisor, Freddie Bray. And I would like to start with this wonderful picture that was taken about a century ago on a beach. And I want you to look how people used to heat from the sun at that time with long covering bathing suits, and how we have changed our attitudes from about sun tanning, from sun hiding behaviors to sun seeking behaviors, with this example of this woman in this sunbed and this man next to a swimming pool with a small shorts. Maybe we can blame that on the French people, especially the French designer Coco Chanel, who launched this passion in the early 1920s. But anyway, so sun exposure is one of the key factors for getting melanoma, and it's also having a fair skin type. And it's really the interaction on those two risk factors that make you at risk of getting melanoma. We here look at data from the GloboCan project. And in 2008, it was estimated that almost 200,000 new cases and 46,000 deaths were due to this disease. And melanoma also ranked as the 6th most common diagnosed cancer in very high human developing index countries. So you see that the rates are highest in, there's no pointer? Okay, in Australia and New Zealand, but the rates are also elevated in some parts of Europe and in Northern America. Over the past 50 years, as David Foreman showed you this morning, the rates have been increasing in most fair-skinned populations. However, during the last decade, several studies published some signs of declines or stabilization in several high-risk countries. And this is why we launched this study with my colleague Friederike Ernmann on incidence trends in melanoma. And for this, we collected data from 84 high-quality population-based cancer registries coming from 39 countries in the Cancer Incidence in 5 Continents annual database. So today I'm going to show you only part of the results, and starting with this histogram with cumulative risk, showing men in blue and women in red, and the percentage range from 0 to 4%. So the highest rates and the highest risk are in Australia and New Zealand, and also USA white people. with the risk of getting melanoma 2 to 3 times higher than in any other countries in the study. So it means that in Australia, 1 man out of 25 will be diagnosed with melanoma during his lifetime. The rates were elevated in Europe, in Nordic countries, Czech Republic, the Netherlands, and in Switzerland. They were much lower in the Eastern Europe countries, in Baltic countries, and in around the Mediterranean Sea. Finally, the burden of cancer, melanoma cancer, is really low in Asia, in South America, and in USA Black people. So you see that there is a clear relationship between the predominant skin type in a country and the geographical location. Okay, these are the age-standardized time trends in melanoma incidence in several countries by age group, by 3 age groups. And what you can see is that uniform increases over all age groups, with the steepest increases in rates in older patients, which are in red, the patients diagnosed at age 65 and over. But what you can see from the distance is that some changes are occurring starting in the 1990s. And if we look at selected countries, 8 selected countries, it's really the same graphs, we only show them bigger. And that's in men only, but it's the same trends in women. We start to see some stabilization or even decline, and most notably among younger people, ages 25 to 44 and 45 to 64. Okay, this will be of interest for the people who attended yesterday's workshop on age period cohort modeling. And the first thing that you see on this incidence rates versus birth cohorts and rates versus calendar periods is that the blue line, the line for birth cohorts, are parallel, meaning that there is a strong cohort effect. And what we see is that there is an increase in risk in all birth cohorts in Canada, USA white people, Norway, and Australia and New Zealand until the cohorts born in World War II, followed by decline that you can see in Canada and or stabilization. Unfortunately, there are no signs of declining risk among those cohorts in New England, Czech Republic, Denmark, and in the other European countries that we study. Those declines are confirmed by the incidence rate ratio in Canada, Norway, Australia, and New Zealand, and not in the other European countries. So the key finding here is really the reduction in incidence in younger patients and in the most recent birth cohorts. And how can we explain this recent leveling off? Well, we might be able to see the effect of prevention campaigns that started as early as the early 1960s in Australia, but were only implemented in Europe in the mid-1980s. How can we explain the country-specific variations? Well, we talked about UV exposure, skin type, and prevention activities in specific countries, but other factors are important, such as HA exposure and high intermittent sun exposure. Intermittent sun exposure is not mentioning Irish weather, but really Nordic people, people from the Nordic countries in Europe going to sunny destinations such as Spain or Italy and basking in the sun on the beaches. Our study also has some limitations. We lack information on body site distribution, histological subtype and tumor grade, and also on individual risk factors such as skin type and sunbathing behavior. In conclusion, well, melanoma is a frequent cancer, especially in the very high HDI countries, but is one cancer that can be avoided. It can be prevented by adopting sun-smart behaviors. So the reduction in melanoma incidence in several high-risk countries among young persons and recent birth cohorts are a good sign for the future burden of this disease, but yet we still need to implement and develop prevention activities, especially in Europe, where the rates continue to increase sharply in most of the countries. The study was published in the International Journal of Cancer this year by my colleague Friederike Ehrmann. And I would like to thank the German, English, and French team, and as well as the population cancer registries for making this study possible. And thank you for your attention.
Is there any question or comment? Stefano Rosso.
Do you have any idea what is happening with mortality? Period and countries?
Yeah, so mortality is still increasing, as I know about Europe, because incidence is increasing. Yet, because of the growing awareness among the general population and also among general practitioners about the risk of melanoma, some melanomas get diagnosed earlier and they give better chance of survival.
You mentioned primary prevention as a possible factor that has altered the trend in incidence, but also secondary prevention could have altered the trend in an opposite direction, because early diagnosis takes over nevi, so it can reduce the incidence of invasive melanoma as a side effect.
Secondary prevention, yes, thank you. That's a good point.
Well, I hate to mention it. Did you take into consideration perhaps an increase in the missingness of reporting due to changes in diagnosis and treatment of melanoma?
It is possible, it is a possible explanation for the differences among European countries, because why would a prevention campaign work so well in one country and not so much in another country, where practices are quite common in Europe? So yes, that's a possible explanation for the differences.
Hideo Tanaka.
Thank you for your nice presentation. Do you have some information of time trend by subsite, by face, body, and legs?
No.
No.
It's one of the limitations of our study in the cancer incidence 5-continent database that we have available. We only have cancer type and not body site.
Okay. If there are no other questions, thank you.
Thank you.
Our next presenter is Dr. Donna Turner, who is the Provincial Director of Population Oncology Portfolio at Cancer Care Manitoba, and she's also an Associate Professor in the Department of Community Health Sciences. Dr. Turner has main interests in research revolve around the use of population-based cancer data as a means of informing cancer control activities. And Dr. Turner is going to speak today on the evidence of a gathering storm from Manitoba, so I look forward to that.
Thank you very much. Good afternoon, everyone. It's really a pleasure for me to be here today to talk to you about an area that is of great concern for those of us in many parts of Canada, and I think from talking to my colleagues worldwide that this is a problem as well, which is concerns about cancer control in Indigenous populations. So this afternoon I'm going to be speaking specifically about some work we've been doing in my home area of Manitoba, which is a province in Canada, looking specifically at our First Nations populations. Now, I myself am not a First Nations person, but you will see that by the list of my collaborators on this slide, this project represents a very broad collaboration, including members of academia, as well as the Cancer Agency, and also, very importantly to us, our collaborators who are in the First Nations in Manitoba as well. So just to get a little orientation, this is the country of Canada, which shows some important dots of population on it. And if we just zoom in here, this is the place that I'm from, which is Manitoba. It is in the longitudinally, the central part of Canada, although for our colleagues or folks who may have visited Toronto, we know that many people consider Toronto to be the center of Canada, but just to point out to you, it's not. So the study objective that we had was, first of all, as I will discuss, to work with the challenge we have of identifying First Nations in our cancer registry, and then assuming we could do that, to describe incidence and mortality trends for a 25-year period, and to look at the differences that we saw by First Nation and non-First Nation categories, as well as by sex. So the reason that this was important to us was that if you look on this graph, it has information from the Canadian Census, which shows that Canada as a whole has a population of about 4% who will self-identify as an Aboriginal or Indigenous person on our census. And in Manitoba specifically, well, you'll see after the Canada bar at the top, the next three jurisdictions are our northern territories, which have a very high proportion of First Nation, Métis, and Inuit populations. But of the provinces, Manitoba and Saskatchewan have the highest proportion of people of First Nation, Métis, or Inuit descent. And you can see on the slide here that our population of about 1.2 million in Manitoba, we have over 100,000 First Nations individuals. And this has increased over the 10-year periods between our previous censuses by about 36%. This First Nations population has increased by 36%, which is 12 times the growth of all other Manitobans. So clearly it's a rapidly growing population, and on top of that we have data as shown in this slide, which for cancer is very worrisome, because we can see that this population also has a very high profile of risk factors that are put them at very high risk for cancer. And then finally, we are very concerned because of where individuals often live, as well as some cultural differences, that there may be significant barriers to cancer care. And at the moment, when we started out, we could not actually talk about what was happening with cancer in this population. So normally, when we have a cancer question, we turn to our cancer registry, which covers the entire population of our province of about just over 1 million. We have a broad registration profile in capturing invasive and in situ cancers, as well as non-melanoma skin cancers and benign brain tumors. And as you can see on this slide, we have the pleasure of having a legal mandate and a long history of being population-based. And again, just some other information at the bottom there that makes the case for us having a high-quality cancer registry. The cancer registry in black, you can see here, are the black font shows the sorts of data that we collect, which are typical of most provincial, or rather population-based cancer registries worldwide. The two pieces of information in blue here are things that our registry has, which many other Canadian and perhaps other internationally cancer registries do not have, which we have made a lot of benefit from in the work that we do. But one of the things that is key, especially when addressing questions of being concerned about a particular part of our subpopulation, is that we have no race or ethnicity variables, and no Canadian registry does. It's something that I think in Canada has just up until recently been considered not done to ask people about their race or ethnic background. So when we are faced with the question of how do we identify First Nations in our cancer registry, we had to turn to thinking about other data sources. And we have in Canada a registry of people who qualify for First Nations treaty payments as a result of historical agreements between our federal government and the original treaty signatories. And this graph just is a prompt for me to remind you to tell you that, in fact, this database really has a historical basis and is used for many other things, including the payment of treaty payments on an annual basis to individuals who are registered. However, we can use this with permissions to link to other data sets, which is what we did in this study. And after going through a fairly extensive approvals process, we were able to acquire access to this information for this project, link it up to our provincial health information file. Like Scandinavian countries, Canada has socialized medicine, so we actually have a register that identifies everyone in our population. And from then, we can then link to the cancer registry and put, for the purposes of a study, a flag on our records that shows who is First Nations and who is not. So that context then leads us to the story of the day, which is to talk about what is happening in incidents in the period 1984 to 2008. And what you can see in this slide is the brownish line shows that what is happening in the non-First Nations population, that is 90% of the population or 85% of the population in Manitoba. But of course, the concern for us today is looking at what's happening with that blue line, which is our First Nations population, and that we can see for both men on the left and women on the right that cancer, although has been traditionally thought to be rare in First Nations populations, is now increasing at an astounding rate, such that we're actually surpassing or poised to surpass the rates in the non-First Nation population. Of course, cancer is not just one disease, and it was important for us to look at what cancers make up these cancers in the population. And on the right, you can see the cancers in Manitoba's population. Like many Western jurisdictions, prostate, lung, colorectal cancers are first for males. But notice that for the First Nations population on the left, that kidney cancer makes an appearance. And when we actually look at the differences in rates, there are many cancers that are still lower incidence in First Nations men compared to non-First Nations. Melanoma, bladder, brain, leukemia, and Hodgkin's disease. But of concern to us are those that are increased. And here we are showing gallbladder and kidney cancers. And just to highlight those here to look at what's happening over time. So the slide on the left is interesting and has caused a lot of discussion locally and amongst our clinical community, because one would not expect such a catastrophic drop in gallbladder cancer. And apparently there had been a period of time where, because of a lot of gallbladder disease in this population, there was a lot of prophylactic cholecystectomy going on, so that may explain that. But we are still continuing to be concerned about the increased kidney cancer incidence on the right. In females, similarly, we did the analysis to look at the difference between what is happening between the First Nations and the non-First Nations, and just to highlight for you that the two cancers that we see in the First Nations population that we don't see so much in the non-First Nation populations are cervix and, again, kidney cancers. And then again, highlighting for you that there are many cancers for which are at a deficit for the First Nations population. But looking at the bottom half of the slide, liver, gallbladder, cervix, and kidney cancers, and again, if we look at the patterns over time, what we can see is the dramatic increase in liver cancers, and again, gallbladder cancer, showing a very similar story to what we saw in men, although at the incidence being at a higher rate. The story for mortality is important to us because mortality includes not just incidence, of course, but what happens to folks in terms of timely diagnosis and effective treatment. So we also extended the study to look at mortality information. which we have captured quite comprehensively in our cancer registry. And what you can see here is quite similar to the story we saw in incidents, that cancer mortality rates for First Nations men and women are increasing at an alarming rate, especially when considering what's happening in the non-First Nations rate. The increase here that we see is increasing at a rate of about 3% per year. That was the average annual percent change, whereas it's really coming down notably or quite noticeably in the rest of the population. When we look at the relative risks or the rate ratios, here you can see that there are some cancers listed at the bottom which show increased mortality rates. So we saw some of these were increased for incidence as well. The good news is that the mortality, for example, for gallbladder is coming down for gallbladder cancer, but for liver cancer, it's going up still at quite a steep rate. Similarly, for women, we see a number of cancers where the news is good news for people who are First Nations. But if we look at those bottom 5 types of cancer, we can see that they are very elevated in this in the First Nation population. Cervical cancer is one that we have been very worried about in terms of access issues to screening, and you can see that it remains to be significantly higher than it is for the rest of the population, and liver cancer rising quite rapidly. Now, one of the things that I just wanted to comment about was that some of the mortality story may be explained by stage. And in our cancer registry, we've had stage diagnosis available to us for the last 5 years of the study. Now, none of these differences were statistically significant, but you can see here that it's because the error bars are so wide, especially on our First Nations data. But still, there is a very worrisome trend to having higher stage diagnosis in our First Nations population. If we look overall, that gives a bit of the story, but really importantly, looking at by site is important. Now, interestingly for us, neither breast nor lung cancer actually shows a difference in percentage of people presenting at stage 4, that is very late stage diagnosis. And that finding for breast cancer was different than our colleagues in Ontario had found. But then when we looked closer, something that is a big concern for us is the percentage of late-stage diagnosis of colorectal cancer in the First Nations population, which is well over 25% now. And also prostate cancer, which was probably the biggest surprise for us in this, because prostate cancer diagnosed at a late stage is only about 12% of our population in general, but almost 20% in this population. The other thing that was very interesting, especially as we look at liver cancer mortality, is to note that liver cancer is diagnosed almost 30% of the time at late stage in our First Nations populations, compared to 20% in the rest of the population. And interestingly, and perhaps curiously, we're interested that kidney cancer, which has traditionally been perhaps more of a differential, one of those diagnoses that hits the list of differential diagnoses for First Nations, actually, people who are First Nations are more diagnosed at an earlier stage than in non-First Nations, which was kind of an interesting finding, which we have yet to fully explore. So just this is my concluding slide, which is to note that historically the picture of cancer as a rare event in First Nations population is changing, and that we are seeing the difference in incidence and mortality rates at many cancer sites. And stage is part of the concern that we have, and something that we must address. And as part of the work that we're doing for cancer control, in terms of looking at encouraging people to respond to symptoms as well as to have access to appropriate staging programs, this is something that we would be looking at very closely based on this information. So all these things need to be taken into consideration in order to make sure that we stem the tide of the impending storm. And so just to, my last couple of slides are just to acknowledge our many partners in this project. Thank you.
Thank you very much, Donna. We probably have time for just one or two questions. Can I just ask you about the First Nation population? Do they have a different life expectancy anyway?
Yes, they do. And current data have been showing it that the life expectancy is lower for the First Nation population than non.
Significantly low? Is it 5 years, 10 years, or?
I don't have that number
Yeah.
right off the top of my head. So, but I'll dig it out and find it.
We have exactly the same situation in Ireland with our Irish Indigenous Irish traveller population, but they have about a good 10, 15-year life expectancy. So cancer is beginning to become a big issue with them, but it wouldn't have been.
And as I'm recalling, the numbers in the bulk were 10 to 15 years for us as well. And certainly part of that is many things that injuries and as well. But now the non-communicable diseases are definitely making a very significant play. Diabetes being significant as well.
Okay. Okay. Oh, there's one here. Yeah.
What proportion of the First Nations would be captured by that treaty database?
Okay, so it's a good question. So the question was what proportion of the First Nations would be captured by the treaty database. These are what we would consider to be status First Nations, so non-status are not captured, but then but it would be a significant proportion, over 90%. But the non-status are a particular concern because they really can fall through the cracks then as well. One of the things I did not mention was we have had inferior ways of identifying First Nations people before, and have been able to show through this study that although we're able to find about 93% of the First Nations people we could find in our province, so the linkage rate was very high, that previous research has only been able to identify 60% or less. So this represented a significant improvement to that.
Linda?
Can I ask you two things about your presentation? First of all, is there evidence from other parts of North America of similar trends in other First Nation communities? And secondly, do you have any information on whether there's differences in patterns of treatment receipt between First Nation and non-First Nation communities?
Okay, so the first part of the question asking about comparisons in other parts of North America. There are studies that are going on in Ontario, for example, and as well as in the United States. David Espy and company are looking very much at this. And certainly many of the things that we're seeing are consistent with the stories that we are hearing and seeing from other analysis in North America. It's important to note, though, that First Nations people, even though we are speaking to them as one group, represent many different subgroups. And so some of the really interesting work I think that David and company are doing is starting to really talk about people at the relations to the actual nations and being able to categorize. Because I think what we see is that the risk factors, or the patterns rather, are different in those groups. As far as treatment patterns, actually that's part of this project as well, a place that we are going to, which is to look at, after we were able to describe incidence, mortality, and STAGE starts to introduce that, but we also have treatment data in our registry, and that is actually the next part. We're looking at screening and treatment to look at variations, and we'll be looking at that not only for First Nations versus non-First Nations, but to look at where in the problem, the north, the far north versus the rural south and the urban, to see if there are differences.
Okay, thank you very much. This wraps up then. Thank you, Donna.
Let's go to India for the next presentation. Atul Srivastava, Time Trend in Cancer in Bhopal, 1988-2005. Atul Srivastava is a senior epidemiologist working for the last 23 years at Population-Based Cancer Registry in Bhopal. He is also principal investigator of a project of Indian Council of Medical Research for improvement of cancer mortality registration in Bhopal.
Very good afternoon to everyone. Thank you, sir. Thank you, ma'am. I come from a registry which is a special registry established in the year 1986 after the gas disaster which caused a lot of mortality and morbidity in Bhopal. This registry was established to to study the carcinogenic effect of methyl isocyanide, which got leaked from the tanks of the Union Carbide factory. And the Special Purpose Registry has already submitted its report. But though I'm talking something different from today, but I just wanted to inform that this is a special registry. The Bhopal registry is under the network of National Cancer Registry Program, which has 28 registries, population-based registries, and 5 hospital-based registries under the network. And in Bhopal, there are both hospital-based registries and population-based cancer registry. The hospital-based registry was started in 2011, but the population-based registry was established in 1986. And ever since its inception, cancer or tobacco-related cancer among men have found to be very high in incidence, and cancer of breast and cervix are high among females. Over the years, there has been a significant change in the trends of the leading sites of cancer observed in Bhopal. Though I have changed the period because I have already finalized the data, so I have considered the period from 91 to 2010. Earlier, I submitted for 2008, but since the data was finalized, I switched it over to 2010. In 1991, if you look at it, lung was the leading site of cancer, followed by tongue, hypopharynx, esophagus, prostate. And if you look at the last site, it's the mouth cancer, which is the 10th ranked cancer in 1991. But over 20 years, the most significant change which was observed was that the mouth cancer rose up to the first leading site of males, and it is the #1 cancer, followed by lung, tongue, larynx, and prostate. Hodgkin's lymphomas, leukemias are also started coming up. This may be a result of the diagnostic facilities which are coming up. Bhopal was not a very good for healthcare system, but now really the healthcare system has taken up, so this might be the reflection of that. And if you look at the trends were analyzed through joint point regression, and the mouth cancer showed a very high APC of 5.3, followed by rise in larynx, prostate, non-Hodgkin's lymphomas, and leukemias. Though the decreasing trend in lung cancer and the esophageal cancers is unexplainable in the modern condition, but other registries of India, some of the registries have also reported similar findings where there has been a downward trend in lung cancer. This may be because of the younger population coming into our town, some age cohort which needs to be investigated thoroughly. Similarly, if we look at the pattern of cancer in females, cervical cancer was the leading site of cancer, followed by breast, ovary, esophagus, stomach, and again mouth was very low down. But in 2010, the most important change was breast and cervix interchanging their position. Breast is now the leading cause of cancer, followed by cervix, and mouth has also come up. The oral cavity cancers, which are rising in Bhopal, both among male and female, may be due to because of high consumption of smokeless tobacco, that is tobacco chewing, which is very prevalent in our region of India, especially in central region. A lot of tobacco is consumed in form of gutkhas, which is available in the market in small packets, which contains betel nut, lime, and tobacco. And mind you, I've seen boys of almost 8 and 10 years consuming tobacco more than 6 to 7 times a day. This might be the reason which has resulted the mouth cancer and the tongue cancer, especially the anterior portion of the tongue, which is showing high incidence in the recent times. Analyzing the trends of the leading sites of female cancer, except cervix, all of the other cancers showed a significant rising trend. And the annual percentage change, as you can see, except for cervix, everyone, and corpus uteri, which has showed no significant change, has been marked in the recent times. This is just to show you what the tobacco consumption, that is chewing, tobacco chewing, is prevalent. Apart from Bhopal, it is Dibrugarh and Ahmedabad which have showed a very high prevalence of tobacco chewing. And you can see these are the TRCs, but if we examine those figures, we see that the oral cavity cancers, especially mouth and tongue cancer, are really high in these three registries. Though the tobacco consumption in Mizoram is very high, but the tobacco usage in Mizoram is much different. There the smoking is very high and the chewing is very less. This is probably why the lung cancer in Mizoram is the #1 leading site in both male and females, and the oral cavity cancers are not that high as compared to Bhopal, Dibrugarh and Ahmedabad. This I just wanted to show you because there is a shift in the mean age of the cancer, especially among mouth cancer among men. Though the cancer is rising in all age groups, but the alarming thing is that the younger age group is showing a significant rise in the cancer. And that is really alarming. Similar are the findings for females. And again, there is a downward shift in the mean age, and the age-specific rate of younger age has gone up. When we look at the tongue cancer among men, though the incidence is slightly on a lower side, but again, the younger age has again shown a higher incidence. This is again what I said, maybe because of the high usage of tobacco chewing, and even the schoolboys are into that. So I just want to conclude that addiction to the tobacco chewing in the young population is a cause of concern for the healthcare system. And cancer awareness and screening programs targeting the young generation are essential for the success of the scandal control activities in this region. I'll just like to take your leave. Thank you.
Is there any question or comment on this presentation? Yes, please.
I think you should add to the translation the epidemiology which Dr. Hans Storm was talking about. That this data would be taken as this thing, but your state was the first state to ban smokeless tobacco.
I just forgot. Our state was the first state to ban the tobacco chewing, the smokeless tobacco in India, and after that almost 12 other registries have banned it, 12 other states have banned it, and recently the Kerala has even banned, that is the 13th state in the country.
So maybe this is a good opportunity to remember that this country, Ireland, has been the first to introduce the ban of smoking in public place in 2004.
Thank you, sir.